Your heart rate is 70 beats per minute. You are sitting on a wooden bench in a room heated to 80 degrees. You have not moved. Within 10 minutes, your heart rate reaches 120 to 150, the range a brisk jog or a moderate cycling session would produce. Your cardiac output has risen 60 to 70%. Every blood vessel in your skin has dilated blood flow to the skin surface, increasing from 5 to 10% of cardiac output to 60 to 70%. You are still sitting, and your cardiovascular system cannot distinguish what is happening from exercise. That alone would be interesting. What makes it extraordinary is what happens at the cellular level, a molecular defense response that exercise alone does not reliably produce at the same magnitude, and that persists for days after the heat exposure ends. It is this cellular response, measured across 2,315 Finnish men over 20 years, that produced one of the most striking cardiovascular mortality findings in modern epidemiology. Now, the cardiovascular stress response, because the physics of how heat trains the heart without movement, reveals why the body cannot distinguish thermal stress from metabolic stress. When ambient temperature rises above approximately 40 degrees, the hypothalamus detects the increasing core temperature and initiates a coordinated cardiovascular response to shed heat. Cutaneous vasodilation begins, the smooth muscle in the arterioles supplying the skin relaxes, and blood flow to the skin surface increases dramatically. The purpose is heat dissipation. Blood carries thermal energy from the core to the skin, where it is lost through radiation, convection, and evaporative sweating. Vasodilation creates a hemodynamic problem. The blood volume must fill a dramatically expanded vascular bed. The skin vasculature, when fully dilated, accommodates several liters of blood that were previously in the core circulation. Blood pressure would drop dangerously if the heart did not compensate. The compensation: heart rate increases, stroke volume increases, cardiac output rises by 60 to 70%. The heart is working harder maintaining blood pressure while the vasculature is maximally dilated, pumping against a peripheral vascular bed that is open to its widest configuration. This is cardiovascular exercise without muscular exercise. The heart is stressed, the blood vessels are stressed. Arterial stiffness measured by pulse wave velocity, the speed at which the pressure wave travels through the arteries, is the mechanism that connects elevated blood pressure to organ damage. Stiff arteries transmit pulsatile pressure to the brain, the kidneys, and the retina, organs that require steady, damped flow and that sustain cumulative damage when the pressure wave arrives uncushioned. Arterial stiffness increases with age, with hypertension, and with sedentary living. Regular sauna use reduces arterial stiffness. The arterial smooth muscle that relaxes during the session is trained to maintain greater compliance between sessions, reducing pulse wave velocity through repeated vascular loading, as Wiles and colleagues documented. Cardiac remodeling from regular sauna use parallels the adaptation endurance athletes developed through years of training, and the parallel is not metaphorical. The repeated volume loading from sauna-induced cardiac output elevation produces eccentric cardiac remodeling. The left ventricle increases its end diastolic volume, the chamber enlarges slightly, and each heartbeat delivers more blood. Resting heart rate decreases because the same cardiac output is achieved with fewer, larger beats. This is the structural change that produces the resting heart rate reduction visible within weeks of regular sauna use. The heart is physically remodeled by the repeated thermal demand, the way a runner's heart is remodeled by the repeated metabolic demand. The remodeling is protective. A heart with greater end diastolic volume and lower resting rate has more functional reserve for any subsequent cardiovascular demand. The endothelial shear stress. The wall sit discussion described the mechanical force on the vessel lining that activates ENOS and produces nitric oxide operates here through a different trigger. The wall sit produces shear stress through reactive hyperemia after capillary occlusion. Heat produces shear stress through sustained elevated flow rate during the vasodilation itself. Different trigger, same endothelial physics, same downstream nitric oxide production, sustained for the entire duration of the heat exposure rather than the 60 to 90 second post-release window the isometric hold provides. Repeated thermal vasodilation across weeks of regular sauna use produces endothelial adaptation. ENOS expression increases, baseline nitric oxide production improves, Endothelium-dependent vasodilation strengthens. Regular sauna users show measurably better endothelial function assessed by flow-mediated dilation than non-users, confirmed by Laukanen's group through flow-mediated dilation measurements. Endothelial dysfunction is the earliest detectable stage of atherosclerosis before plaque forms. Before the artery narrows, the endothelium loses its ability to produce adequate nitric oxide. The vessel stiffens, inflammatory cells adhere more readily, and the cascade toward plaque begins. Heat exposure targets the exact tissue layer where cardiovascular disease starts and the layer that declines fastest with age. Endothelial enos activity decreases decade by decade, nitric oxide bioavailability drops, arterial stiffness increases. The repeated thermal shear stress the sauna provides becomes proportionally more important as the baseline endothelial function it supplements is declining. The 60-year-old's endothelium needs the stimulus the 30-year-old's produces adequately on its own. Heat shock proteins next, because this is the molecular defense that makes heat categorically different from exercise as a cardiovascular stimulus. When core temperature rises above approximately 38.5 degrees, which occurs within 10 to 15 minutes in a sauna at 80 degrees Celsius throughout the body, activate a molecular defense program called the heat shock response. The primary effectors are heat shock proteins, molecular chaperones, synthesized in response to thermal stress. HSP70, the most abundant heat shock protein, binds to unfolded or misfolded proteins inside the cell and assists their correct refolding. Under thermal stress, protein structure destabilizes the three-dimensional shapes that proteins require for function begin to unfold. HSP70 stabilizes these proteins, preventing aggregation and restoring function. After the heat stress resolves, HSP70 levels remain elevated for 24 to 72 hours, providing ongoing protection against protein damage from any source. The morning after a sauna session, every cell that felt the heat is carrying this defense, including the cardiac cells that would need it most during a heart attack. The protection is not specific to heat. A cell that produced HSP70 in a sauna is better protected against oxidative damage, against inflammatory damage, against the ischemic damage that occurs during a heart attack when blood supply is temporarily interrupted. HSP90 works downstream, chaperoning signaling proteins involved in cell survival and stress resistance. HSP90 stabilizes the enos enzyme itself, the enzyme that produces nitric oxide. More HSP90 means more stable enos, which means more nitric oxide production between sauna sessions. The heat shock protein produced during the session improves the vascular physics for days after the session ends. The heat shock protein response is a preconditioning mechanism. A cell that has been heat stressed and produced HSP70 and 90 is more resistant to subsequent stress of any kind. The heart cells that produce these proteins during a sauna session are better protected against ischemic damage for 24 to 72 hours afterward. The window between sessions in a 4 to 7 times per week protocol covers the entire week. The cardiac protection is continuous because the protein elevation from each session overlaps with the next. This is cardiac preconditioning through heat. The sauna, training the heart's cellular defense systems the way exercise trains its muscular capacity, but through a different stress pathway. Exercise stresses the heart through metabolic demand. Heat stresses it through thermal load. Both produce adaptive responses that protect the organ against future damage. The combination provides broader protection than either alone because the two pathways activate different molecular responses that converge on one protective outcome. HSP production capacity itself declines with age. The heat shock response is less robust at 60 than at 30, which means the preconditioning window the sauna opens is the window the aging cell most needs and least produces on its own. Regular heat exposure maintains a chaperone baseline the aging cell would otherwise lose. Breathless discussion named heat shock proteins as part of the vigorous threshold's antioxidant response. The mechanism here involves an identical class of molecules, but the production pathway differs. Vigorous exercise produces HSPs through the combined thermal and metabolic stress of intense muscular contraction. Heat exposure produces HSPs through thermal stress alone at a higher and more sustained core temperature elevation than exercise typically achieves. The sauna reaches 38.5 to 39 degrees within 15 minutes and maintains it. Most moderate exercise sessions never reach this core temperature. Vigorous exercise may reach it briefly. The sauna sustains it for the duration of the session, producing a stronger, more sustained HSP synthesis signal than exercise at any intensity below exhaustive provides. Finnish data next. This is where the mechanism meets the mortality outcome across 20 years and 2,315 men. Laukkanen and colleagues at the University of Eastern Finland published in JAMA Internal Medicine in 2015 the results of the Kuopio ischemic heart disease risk factor study. The cohort, 2,315 men aged 42 to 60, followed for a median of 20.7 years. Sauna frequency and session duration were reported at baseline. Results: adjusted for age, BMI, blood pressure, cholesterol, smoking, alcohol, diabetes, and physical activity, 1 session per week served as the reference group. 2 to 3 sessions per week produced a 27% lower risk of fatal cardiovascular disease. 4 to 7 sessions per week produced a 50% lower risk of fatal cardiovascular disease. Dose response was monotonic: more sessions, more protection, no plateau within the range studied. The effect held after adjusting for every conventional cardiovascular risk factor the researchers could measure. It held across age subgroups, across fitness levels, across BMI categories. Sudden cardiac death within 1 hour of symptom onset, the most feared cardiac outcome, showed an even steeper dose response. 4 to 7 sessions per week was associated with 63% lower risk compared to 1 session per week. All-cause mortality: death from any cause showed a 40% reduction in the highest frequency group. A 50% reduction in cardiovascular mortality from sitting in a heated room 4 times per week is an effect size that rivals the most effective pharmaceutical interventions in cardiology: statins, ACE inhibitors, beta blockers. The mechanism: cardiovascular conditioning through heat stress, heat shock protein-mediated cellular protection, and endothelial function improvement, provides the biological plausibility the epidemiological association requires. Those numbers: 50% cardiovascular mortality reduction, 63% lower sudden cardiac death risk, put the sauna into the weekly schedule permanently once the Laukkanen data was placed beside the heat shock protein timeline. Laukkanen's group published a second analysis from the Kuopio cohort, this time tracking dementia and Alzheimer's disease across the 20-year follow-up. 4 to 7 sauna sessions per week was associated with 66% lower risk of dementia and 65% lower risk of Alzheimer's disease compared to 1 session per week. The mechanism connects to HSP-mediated protein maintenance: amyloid beta and tau, the misfolded proteins that aggregate in Alzheimer's disease, are substrates for the chaperone machinery that heat shock proteins provide. HSP70 assists the refolding of proteins that would otherwise aggregate into the plaques and tangles that destroy neural tissue. Regular heat exposure maintains the chaperone capacity that aging reduces the protein repair machinery running at a higher baseline between sessions because the HSP elevation from each session overlaps with the next. Cardiovascular and neurological findings from this cohort reinforce each other. Cardiovascular health is itself a predictor of dementia risk through cerebral perfusion. The endothelial improvement the sauna produces maintains blood flow to the brain. The HSP elevation maintains the protein repair machinery inside the neurons, 2 pathways converging on the same neurological outcome through one thermal intervention. You now know the cardiovascular mimicry, the molecular defense, and the mortality data. The question changes from what the sauna does to the heart and the blood vessels to what the dose means in practice and who should approach it with caution. Well, the dose, because the Finnish data reveals specific thresholds in both duration and temperature that determine whether the heat shock response activates. Sessions longer than 19 minutes were associated with greater benefit than sessions of 11 minutes or less. The duration matters because the heat shock response requires core temperature elevation above approximately 38.5 degrees, and sessions that are too short may not reach this threshold. The 80-degree, 20-minute protocol reliably raises core temperature to 38.5 to 39 degrees, the range where HSP70 synthesis activates. Infrared saunas operate at lower air temperatures, 45 to 60 degrees, using infrared radiation to heat the body directly rather than heating the air. Studies on infrared sauna show cardiovascular benefits at these lower temperatures. suggesting that the critical variable is core temperature elevation rather than air temperature. If the session achieves a core temperature rise above 38.5 degrees, the heat shock response activates regardless of the heating method. The infrared sauna reaches the threshold more slowly and may require longer sessions, 25 to 30 minutes, rather than 15 to 20, to achieve equivalent core temperature elevation. If no sauna is available, a very hot bath at 42 degrees for 20 minutes produces a modest core temperature elevation and a partial heat shock response. Brunt and colleagues at the University of Oregon documented cardiovascular adaptations from repeated hot water immersion, reduced resting blood pressure, and improved endothelial function after 8 weeks of regular hot baths. The effect is smaller than traditional sauna, but larger than no thermal intervention. The cardiovascular physics is identical: heat in vasodilation, cardiac output increase, endothelial shear stress through a more accessible delivery method. And then the complementarity with cold, because cold and heat are complementary cardiovascular stimuli operating through opposite mechanisms. Cold activates the parasympathetic nervous system, vagal tone, heart rate reduction, peripheral vasoconstriction. Heat activates a cardiovascular training response, heart rate elevation, peripheral vasodilation, cardiac output increase. Cold protects acutely through the dive reflex and the vagal shift. Heat protects chronically through cellular preconditioning, endothelial adaptation, and accumulated cardiovascular fitness from repeated exposure. Cold is a break, heat is training. The body benefits from both through different mechanisms at different timescales. Finnish tradition combines both sauna followed by cold water immersion or snow contact. The rapid transition from maximal vasodilation to maximal vasoconstriction provides an extreme vascular training stimulus. The vessels exercise through their full range of constriction and dilation in minutes. This is vascular calisthenics. The blood vessels themselves trained like muscles through repeated contraction-relaxation cycles that neither heat alone nor cold alone produces. Safety matters because the cardiovascular stress that makes the sauna therapeutic is the stress that makes it dangerous in specific conditions. Plasma volume expansion is an adaptation that endurance athletes spend months achieving through training and that regular sauna use produces through a different pathway in weeks. Repeated heat exposure triggers aldosterone-mediated sodium retention, which increases plasma volume by 7 to 12%. More plasma volume means the heart fills more efficiently per beat. Stroke volume increases at rest, resting heart rate decreases, and the cardiovascular system operates with greater reserve capacity during any subsequent demand. For anyone over 55 whose plasma volume has contracted from chronic mild dehydration, reduced physical activity, and the age-related decline in thirst sensation, the sauna restores circulatory volume that sedentary indoor life progressively withdrew. Systemic inflammation measured by C-reactive protein, the blood marker that predicts cardiovascular events, independently of cholesterol, decreases with regular sauna use. The anti-inflammatory mechanism operates through a pathway anti-inflammatory medication does not access. HSP70 directly inhibits NF-kappa B, the master inflammatory transcription factor that drives the production of inflammatory molecules throughout the body. When HSP70 levels are elevated between sauna sessions, NF-kappa B activity is suppressed at the transcriptional level. The inflammatory program is turned down at its source, rather than blocked at its endpoint the way NSAIDs operate. For anyone carrying chronic low-grade inflammation from visceral fat, from poor sleep, from sedentary habits, the conditions that characterize the majority of adults over 55, the sauna provides anti-inflammatory signaling through a molecular pathway that aspirin and ibuprofen cannot reach. Growth hormone responds to heat exposure through the hypothalamic temperature sensors. Sustained core temperature elevation above 38.5 degrees stimulates growth hormone, releasing hormone through hypothalamic temperature sensors rather than through afferent nerve signaling from contracting muscle. The growth hormone elevation from a 20-minute sauna session reaches 2 to 3 times resting levels comparable to the exercise-induced elevation, arriving without the muscular demand. For anyone whose musculoskeletal limitations prevent the vigorous exercise or isometric loading that normally stimulates growth hormone release, the sauna provides the endocrine signal through thermal stress alone. Unstable angina, recent myocardial infarction, decompensated heart failure, severe aortic stenosis, and uncontrolled hypertension are contraindications. The cardiovascular stress of heat exposure can be dangerous when the heart cannot accommodate the increased output demand or when the vasculature cannot handle the pressure changes. Anyone on medications that impair thermoregulation, beta blockers blunting the heart rate response, diuretics reducing the plasma volume available for sweating, anticholinergics impairing the sweat glands should consult their physician before regular sauna use. Hydration is not optional. The sweating response during a sauna session produces half a liter to a full liter of fluid loss. Dehydration reduces plasma volume, increases blood viscosity, and raises the risk of thrombotic events. The morning cardiac risk from blood viscosity is replicated in miniature by entering a sauna already dehydrated. Water before, during, and after the session. The Finnish data was collected from men with established sauna habits. They had been using saunas for years. Beginning sauna use for the first time should start with shorter sessions at lower temperatures. 10 minutes at 70 degrees, building to 15 at 75, then 20 at 80. The cardiovascular adaptation that makes regular use safe is itself a product of gradual exposure. The endothelium needs time to upregulate. The heat shock protein response needs repeated sessions to reach its full protective magnitude, and the baroreceptor sensitivity needs to adjust to the repeated vasodilation recovery cycles. Alcohol and sauna is a specific risk combination. Alcohol vasodilates independently. Adding pharmacological vasodilation to thermal vasodilation produces a combined drop in peripheral resistance that can overwhelm the heart's compensatory capacity. Hypertension, syncope, and in rare cases cardiac arrhythmia can result. The Finnish epidemiology on sauna-related deaths identifies alcohol consumption as the primary risk factor. The sauna itself is remarkably safe in sober, hydrated individuals. The deaths occur when the vasodilation exceeds what the heart can compensate for, and alcohol is the variable that pushes the vasodilation beyond the compensatory threshold. And then heart rate variability, the beat-to-beat variation reflecting parasympathetic tone, improves measurably with regular sauna use. The mechanism operates through the repeated autonomic oscillation. Each session drives the cardiovascular system into a sympathetically activated state. Elevated heart rate, increased cardiac output, peripheral vasodilation, followed by a recovery phase where the parasympathetic system reasserts control. Repeated oscillation trains the autonomic flexibility that aging and sedentary living progressively reduce. For anyone whose resting HRV has been declining, and it declines in most adults after 40 without specific intervention, the sauna provides autonomic training through thermal stress that complements the autonomic training. Cold exposure provides through the opposite thermal stimulus. Heat trains the system through sustained sympathetic activation. Cold trains it through acute activation followed by parasympathetic rebound. Both improve the autonomic flexibility that determines cardiovascular resilience. Blood pressure responds in two phases. The acute phase begins with the first session vasodilation and nitric oxide production reduce peripheral resistance for 2 to 4 hours after each exposure. The structural phase emerges across 4 to 8 weeks. As ENO's expression increases permanently in the endothelial cells, the baroreceptors reset to accept the lower post-session pressure as the new baseline, and the arterial compliance improves through repeated smooth muscle relaxation. A home blood pressure monitor reveals the shift. Early on, sauna day readings are lower than non-sauna day readings. As the structural adaptation develops, the gap closes. The non-sauna day numbers drop toward the sauna day numbers because the adaptation persists between sessions. Regular sauna use trains the sweating response itself. Sweat glands increase their output, begin producing sweat at a lower core temperature threshold, and reabsorb more sodium, producing more efficient cooling with fewer electrolyte losses. For anyone over 55 whose thermoregulatory efficiency is declining, the sauna maintains a heat dissipation capacity that aging without thermal training progressively degrades. Discomfort during the final minutes of a sauna session, the urge to leave, the sensation that the heat has become too much operates through a molecule called dynorphin. Dynorphin is an endogenous opioid the brain releases in response to thermal stress, and it produces the dysphoria, the unpleasant "I need to get out" signal that intensifies as core temperature rises. The biology of what follows is the reason the discomfort matters. Dynorphin release triggers a compensatory upregulation of mu-opioid receptors throughout the brain. More receptors means greater sensitivity to the brain's own endorphins. Beta endorphin released after the session binds to a receptor field that the dynorphin expanded. The mood elevation, the deep calm, the sense of well-being that arrives 15 to 30 minutes after leaving the sauna is endorphin binding to an upregulated receptor system. The discomfort during the session is the receptor expansion. The well-being after is the expanded system responding to its own endogenous ligand. Cold exposure produces mood elevation through norepinephrine and serotonin. The sauna's mood mechanism operates through the dynorphin-endorphin axis, a different pathway producing a different quality of well-being through a different neurotransmitter system. The calm, 20 minutes after leaving, carries a different weight now that the dynorphin pathway is visible, not relaxation, but pharmacology the body runs on itself. Chronic musculoskeletal pain responds to sustained heat through mechanisms that medication addresses incompletely. Heat increases tissue extensibility, fascia, joint capsules, and muscle fibers become more compliant at elevated temperatures, reducing the mechanical stiffness that produces morning pain and restricted range. Heat reduces muscle spasm through gamma motor neuron inhibition. The sustained thermal input suppresses the reflex arc that maintains protective muscle contraction around painful joints. And the endorphin release from the dynorphin pathway provides centralized pain modulation that operates at the brain level rather than at the tissue level where NSAIDs work. For anyone managing chronic back pain, hip arthritis, or shoulder stiffness conditions that affect the majority of adults, over 60-20 minutes of sustained heat provides pain relief through 3 simultaneous mechanisms that a single medication cannot replicate because each mechanism operates through a different biological pathway. Well, the passive dimension, because cardiovascular conditioning carries specific relevance for anyone whose musculoskeletal limitations prevent exercise. Severe arthritis, post-surgical recovery, chronic pain conditions, peripheral neuropathy, limiting balance. These conditions reduce or eliminate the ability to achieve cardiovascular training through movement. The sauna achieves cardiac output elevation, endothelial shear stress, and HSP production through thermal stress alone. No joints loaded, no muscles contracted, no balance required. For anyone who has been told to exercise for cardiovascular health, but whose body cannot perform the exercise the recommendation assumes, the sauna provides the cardiovascular training stimulus through a channel the musculoskeletal system does not gate. Evening sauna use 2 to 3 hours before bedtime connects to sleep onset physiology through core temperature physics. The sauna produces maximal peripheral vasodilation. After leaving the sauna, the dilated peripheral vasculature dumps core heat, rapidly accelerating the core temperature decline that the hypothalamus requires for sleep onset. The sauna before bed is a bath at higher intensity, producing a more dramatic vasodilation, a faster post-exposure core temperature drop, and a stronger sleep onset signal than hot water immersion provides. The cardiovascular benefits and the sleep benefits operate through one thermal intervention simultaneously. The session that protects the heart also accelerates sleep onset through the temperature physics. That convergence cardiovascular conditioning without movement through an endothelial adaptation that targets the tissue layer where disease begins, a molecular defense program that persists for days between sessions, a dementia risk reduction operating through both vascular and protein maintenance pathways, and a mortality reduction across 20 years that rivals the best pharmacology cardiology has produced is why 270 minutes per week in a heated room. The dose the Finnish data identified carries more cardiovascular physics per minute than any passive intervention the field has measured. 20 minutes. A heated room, your heart rate climbs to 120, your cardiac output rises 60%. Every cell that feels the heat activates a molecular defense program, HSP70 stabilizing proteins against damage from any source, HSP90 supporting the enzyme that makes your blood vessels flexible, a preconditioning response that protects cardiac cells for days after each session. 20 years. 2,315 men. 4 sessions per week. 50% lower cardiovascular mortality, 63% lower risk of sudden cardiac death, 40% lower risk of dying from any cause. The sauna does to your cardiovascular system what movement does to your muscles, stresses it gently, repeatedly, and lets the adaptation accumulate until the organ is harder to damage.